Our next session is on addressing the challenges and unmet needs in global cancer care and capacity building. Our session chair is Dr. Benjamin Payson, Vice Chair of the Clinical Affairs and Clinical Professor in the Division of Surgical Oncology, Department of Surgery here at City of Hope. Dr. Payson received his medical degree from Universidad de Chile and did his general surgery residency training at the University of Arizona. He joined City of Hope as a surgical oncology fellow in 1990. As the vice chair of the Department of Surgery, he has helped expand the program dramatically and develop several patient-focused multidisciplinary clinics. He has developed one of California's leading center for minimally invasive surgery in oncology. Castle Connelly and Pasadena Magazine named him in the America Top Doctors. Welcome, Dr. Payson.
Thank you very much. I really appreciate the invitation, opportunity to share with all of you our ideas about global oncology and global diversity in oncology. As a South American myself, I just came back from Chile after being 2 weeks and visited my colleagues there. This was our 40th school reunion from medical school. And I'm actually in Buenos Aires next week. So I have deep connections to South America. And I believe that the capabilities of South American physicians and the hospitals are among the best in the world. And I know we have some difficulties and some challenges, but the quality of the physicians and the training I received, actually, I did my first surgical residency at the Catholic University in Chile before I came to the United States. And the quality of the training of the physicians in South America, especially in countries like Brazil, Chile, Argentina, is superb. So let me introduce the next speaker. He's my friend, my colleague for many years, Dr. Vijay Trisal. He's a surgical oncologist. He's a Norman and Melinda and Payson professor of medicine, and he's the chief medical officer at City of Hope. He obtained his medical degree from the Government Medical College in Kashmir, India, and completed his general surgery residency at Providence Hospital and medical centers in Southfield, Michigan, followed by training at the City of Hope, where he did his surgical oncology fellowship in 2002. He, as the Chief Medical Officer at City of Hope, Dr. Trisal focuses on patient experience, the quality of care delivery, and graduate medical education across the enterprise. He has been at the center of immunotherapy and technological advancement towards the cure of melanoma, sarcoma, and rare life-threatening diseases. He is passionate spokesperson for individualized care, incorporating consideration for each person's specific needs and expectations into treatment decisions. He also led the successful implementation of Connect Hope, a transformation implementation of complete health record system across the enterprise. Dr. Trisal is not only all of this, he is one of the most finest physicians. He is the most superb surgeon. And I know City of Hope gained tremendously from his leadership, but I miss him in the operating room. He is my best friend. Dr. Trisal will speak today about the global diversity in oncology.
Ben, thank you so much. Thank you for that kind introduction. And just to tell folks about how many people you have trained across this country and how that has impacted global care. I know I come from a third world country, seeing the level of care, and what you mentioned is the amazing people who want to deliver that care, but the system does not lend itself to give the same care that we would do. Even in this country, the differences we see in outcomes, and I'm going to take the next 10 minutes to 15 minutes to talk about that a little bit, and some of the interventions we as City of Hope leaders have implemented that has helped at a smaller level, but that can be a model that can be extrapolated throughout the country, and I would say throughout the globe. While I don't have a solution for how we do that, we have a good template to do that. Let me get some facts on the ground first for everybody who is online. We'll go to the next slide, please. So here is some startling facts. Facts that when we were in 1950s, medical knowledge took 50 to 60 years to double. So what we're doing in surgery, what we're doing in medical oncology, what we were doing in supportive care was knowledge took a long time. So we had time to adapt to that. We had time to learn that. We had time to incorporate that into our practice. Today, and this data, what you see here, that says that medical knowledge doubles in only 73 days, it's about 2 to 3 years old. Today, medical knowledge doubles in less than 2 months. So realize if you are taking care of diverse group of patients where disease complexity has changed, where new treatments have come about, unless you are up to date on that, unless you are focused on that, you're not going to be able to deliver great care. You're not going to be able to deliver the right treatment. On your right side, you will see that new drugs, new molecules, targeted therapies, monoclonal antibodies that have been developed, CAR T cells that have been developed. Just in 2018, there have been 849 molecules that were developed. This is a 77% increase over the last decade. And when you have multiple number of therapies, when I graduated from this program, I knew what the treatment for lymphoma would be, what would be the regimen. I didn't prescribe them, but I knew today I am completely out of touch with that. And when I look at doctors that are in the country, in the world, that don't have access to this information, that are treating wide variety of diseases, that were dealing with less resources, this gap becomes bigger and bigger. The second thing I want to bring out is that outcomes are better in those areas, in those specialty hospitals where you are dealing with just that one disease. You saw this in surgical parlance, or even in areas where you have centralized care, whether that is in Sweden, that is the Scandinavian countries, where a sarcoma surgery can only be done at 2 or 3 different hospitals. Their outcomes are much better than our outcomes. The treatment modalities, the aggressiveness of the surgery is much more focused in this one area. Now, for a vast country like the United States, and in countries like, I'm talking about India or just in Brazil visiting Sergio, the population is so widely distributed that may not be able to centralize. So what do we do in those areas? And I'm going to mention that in a few minutes. This is data from NCI and this is data from the California database, where we learned that in California, only 50% of the patients receive NCC and concordant care. Now, when we developed, we're the founding members of the National Comprehensive Cancer Network, and that develops these algorithms and these pathways of what the right treatment would be. If we took those pathways, those are basic pathways, and extrapolated them to, hey, how many people get that treatment? Only 50% of the patients, even in a state like California, which is the 5th largest, 6th largest economy in the country, if I were a country, there is discordance in there. The fourth thing that I want to point out is that a lot of the treatment modalities that we have, if they don't follow algorithm, if you don't have the right diagnosis, where 10% of the pathology that is read by non-specialists actually is not the correct pathology. So when you don't have the correct pathology, you're never going to get to the correct treatment, and you're not going to get to the right outcome. So there is wastage in the system based on the diagnosis not being right, the treatment not being right, or the dose not being right. So that 20 to 25% wastage contributes to this increasing burden on cost and outcomes not being that great. The other thing is the advancement. I talked about how quickly science changes and how quickly genomic mutations come to the fore. Many of these cancers, and I know that Dr. Taylor is going to bring some of this up in breast cancer, that 10% of these cancers are driven by inherited genetic mutations. And if we are not understanding that early, not only are we not able to give the right treatment to those patients, but we also don't have an idea about how to prevent those cancers in the family members or in the relatives of those patients. So that impact is a significant impact. Next slide, please. This data really shudders me to some extent. Let me explain this. This is basically data from NCI and CDC that looked at oncology-specific survival. So how many people die based on where they live? Those were the only two metrics. How many people, what is the survival of any cancer, which is age-adjusted, per 100,000 population? It ranges anywhere from 16, which is the blue color in this graph, to up to 230 deaths per 100,000. That is the red color in this graph. So just because of where you live, and that obviously has a lot of things behind it. What is your socioeconomic status? What is the access to an NCI designated cancer center? What is your insurance? What is your education level? What are you focused on in that Maslow's hierarchy? Are you going to spend the next dollar towards sending an insurance or buying food for yourself and your children? All of those are impacted. All of those are factors that can determine what is your survival. But realize, how can we accept this? That just based on geography, where you live, and if you take this color coding and spread it across the world, spread it across Southeast Asia, Africa, South America, Europe, you'll find that these deserts of access to care, deserts will lead to inequitable survival. So there's a treatment available, but it is not available to you because you live in a certain area or you don't have access to that. Next slide. This is data that was collected based on where you got treatment. So City of Hope is one of 10 freestanding PPS exempt cancer centers in this country. And when we look at the data of survival, 5-year survival by hospital category, we fall into this PPS exempt hospital category. And very recently, when I looked at this data, City of Hope's data and survival was better than what you would expect based on the disease of the patient. So we are in this 53% category. This is again a very broad generalization of specific cancers that are treated at these patients, at these hospitals. If you take NCI designated comprehensive cancer centers that are not these 10 PPS exempt centers, the survival is lower. If you take other academic medical centers, the survival is further lower. And if you take other hospitals that are not specialized, the survival is further lower. So outcomes are better at leading cancer centers, and only about 15 to 20% of these cancers are treated as at these NCI designated cancer centers. So even in this country, which is a leading economy in the world, we have discrepancies in that care, in that delivery. And you can take this and you can take it at those other countries that I was talking about, and you will find that that discrepancy is dramatically more. Next slide, please. So what is some of the solutions that we have found out? This is data from Access Hope. Many of you who are at City of Hope will know that Access Hope is one of our companies, one of our initiatives that we started many years back to just provide second opinions. So we partner directly with employers, and those people that are working at these big companies, they have access to a second opinion in City of Hope. So these are hundreds and hundreds of patients that had a treatment modality that was chalked for them. So somebody is in northern Seattle and they're working at, let's say, Amazon, and they went to the local doctor and got the treatment, and here is a treatment modality. They have access to second opinion at City of Hope. And when we tabulated the data on all of them, we realized that 89% of those patients, there is a difference in what we would have recommended as a specialty cancer center, what our doctors would have recommended based on algorithms, based on their specific genetic mutation, and what we would have done. So if you look at this data, you'll see that in about 52%, we agreed with the initial treatment with minor recommendations. Some of those minor recommendations can have impacts on survival, can have impacts on complications, can have impacts on toxicity, can have impacts on whether you go down to a clinical trial or not. We agreed around 11%. So that's where this 89% comes from. In 11% of the times, we agreed with the initial recommendation. The biggest thing that was a shock to me was that we disagreed with significant recommendation in 7% of the patients. So about 7 to 10%, and with moderate recommendation in 30% of the patients. In that group of patients, if they had seen a subspecialist or a super specialist, the treatment recommendations that would have impact on long-term outcome, that would have impact on long-term complications, that would have impact on toxicities, that would have impact on being eligible for a clinical trial somewhere, that change would have impacted how their next treatment would be meted out to them. And these are all significant. If we have patients that face toxicities where now you would have to decrease the dose of the drug, that would lead to poorer outcome. So this is not just that you're bearing a toxicity, this is an impact on whether you can tolerate that treatment and whether you can continue with the treatment or stop that treatment. So this is a model that I would propose for widening. We now have about 3 million members in Access Hope that have access to this, where they can get a second opinion from a specialist. And this doesn't need to come to City of Hope. This is not a patient that needs to come from Wyoming to come directly to City of Hope. That treatment can be meted out locally. And you will realize that most of the doctors that are involved with this, and we work directly with doctors where we get the doctor on the phone and are able to communicate with them as to how we would treat that patient and if that care can be delivered locally. There may be some care like complex bone marrow transplantation, CAR T cells, complex surgeries, reconstructions that may not be able to be delivered locally. And for those patients, a centralized care would be ideal. I think one of the great things the City of Hope has done many, many decades back is in being the founding member of the NCCN, those algorithms that we have open to everyone. So basically anybody, whether that is in India or that is in South Africa or that is in China somewhere or South America, they can access those NCCN guidelines. And that is one way of being able to create this global access to opinions from specialized treatment teams. Now, one of the things with NCCN guidelines is that some of it can be very vague. It can be consider this, consider PET scan, or consider this treatment. And when you go and talk about what resources are available, that treatment will need to be individualized. And that is what Access Hope, this treatment modality does. That is what this initiative does, and providing access to everybody else. Next slide, please. And this is my last slide. With providing access to make that whole chart blue and not have red in there, we will have to challenge a few sacred cows. Some of those sacred cows is that when you have narrowed networks where you only are able to go to 2 different places and are not able to access super specialists, that you can control cost. But we really have to redefine that value equation, is that we want to make sure that when for a patient you talk about value, it is not just value of how long you live. It is how much difficult it is to access a system. How difficult is it to get an authorization? How difficult it is to get radiation? Can you get treatment at home? That is one of those sacred cows we will have to challenge. We will also have to focus on using advanced care. For example, clinical trials. At City of Hope, 33% of our patients at some point in time are on a clinical trial. So you're taking those tomorrow's treatments, are able to give them today. And with that, you're able to identify the group of patients that would benefit from that treatment, learn from that treatment. With our focus on precision medicine and genomic understanding of disease, it will give us further insight into how we can easier identify that population that is going to be best benefiting from that clinical trial. So that access to clinical research becomes a critical component of access to care. Access Hope has demonstrated it in this smaller population. What we want to do is make sure that we can expand it across counties, across states, and across countries as such. So I'll stop here and will be available for any questions, any thoughts, or any comments that you all have, and will be here present for Dr. Taylor's presentation.
Thank you very much, Dr. Trisal. That was very informative and also very thought-provoking. Any questions for Dr. Trisal regarding the topic? So just as we wait for the attendants to ask questions, so what is CDFO doing to have equity in outcomes of cancer? How are we improving care? How do we provide access to care?
So one of the things that we are doing, Ben, as you know, we are a not-for-profit. We have a financial assistance policy for patients who may not have insurance, who may not be getting right care, and we have, in fact, opened that up so that more people can access that. But I think the bigger impact we'll have on something that you have done, others have done, is training the surgeons and the medical oncologists of the future that can go out into the communities where they can run tumor boards, where they can change care, where they can be directly impacted with care. The example I gave with Access Hope is actually a remarkable example. I hope that we can expand it across counties, where second opinions on patients we would never see, on patients that never have a medical record number here, but having these opinions that would guide their care. Granted that it is a limited number of patients that we have started yet, but we have a proof of concept that when you have specialists who have understanding of the disease, get involved with the care and create a pathway that you can improve outcomes, that you can decrease costs. Those are the two things that I think are so critical that are not counterintuitive. It's not that expensive care is always best care. In fact, I would challenge people that majority of the times, expensive care is poorer care. It doesn't lead to better outcomes. So City of Hope is doing 2 or 3 things. Number one, we talk about democratizing care, about expanding into the community, something, Ben, that you have led, that you don't, if people are not able to come to a designated cancer center, we take the care to them, we take the theater to them, and we are able to go to those places where outcomes were poor. You and I initially talked about Lancaster, where outcomes for lung cancer were the worst in all of LA County. It was that zone 1. And the positive margins in breast cancer, esophageal cancer were very, very high. And our intent was to just educate and operate locally, but that expanded into this huge network that now takes care of 40,000 new patients across Southern California, and all those patients are impacted by what City of Hope does. I would love for us to have much more global impact, something that Edwin has done and Roxana and Linda have done, and is expanding to Latin America, where those opinions can be tailored and we can learn from each other. So those are a few things that I can tee up right now.
Okay, so to answer some of those questions and to really give examples of how we can change care and really change outcomes, let me introduce the next speaker, Dr. Lesley Taylor. Lesley Taylor is an assistant clinical professor of the Division of Breast Surgery, Department of Surgery at City of Hope. She obtained her medical degree from the New York Medical College She completed then her breast surgical oncology fellowship at Columbia University in New York and her residency in general surgery at Albert Einstein College of Medicine. For over a decade, Dr. Taylor has been working with breast cancer patients and has brought her passion for global health and surgical expertise to Ecuador and Ethiopia, where she works to help eliminate disparities in cancer care through grants from the Susan G. Komen Roche African Research Foundation and Breast Cancer Care and Research Foundation, the College of American Pathologists and Philanthropy. Dr. Taylor is developing pathology capacity, patient advocacy, and breast cancer specific databases, training researchers and medical professionals, and upgrading and decentralizing oncology care in Ethiopia. She's a recipient of the Patient's Choice Award. Dr. Taylor is really an amazing human being and physician. What she's done by her passion and her own desires, and really City of Hope community follows her. She is the one who has made the difference, and she'll talk to us about City of Hope Ethiopia Breast Cancer Initiative. Welcome, Dr. Lesley Taylor.
Thank you so much. That's a very kind introduction. Okay, so in this talk, next slide, please. In this talk, my objectives are to describe the magnitude of breast cancer and the mortality in sub-Saharan Africa in the context of Ethiopia. I'll also discuss international collaboration and incremental progress, specifically in Ethiopia over the last decade, working in the setting and the context of extremely limited resources. I'll also share some practical aspects of program building and discuss an approach to building sustainable infrastructure for future work. Next slide, please. So breast cancer is the most common cancer worldwide, and the mortality is highest in sub-Saharan Africa. And also, 1/3 of breast cancer deaths in sub-Saharan Africa can be prevented in the next decade by improved diagnosis and treatment. Next slide, please. So how does Ethiopia fit into this African context? Ethiopia is the second most populous country in Africa, second to Nigeria. It's also one of the lowest resourced countries. It has one of the lowest GDPs. It is a country of 114 million people. Urbanization is growing, but 80% of the population is rural. I love these pictures, which really bring home the hard work of being a woman in this country. When I first went to Ethiopia in 2011, there were 3 medical oncologists in the country and 1 functioning cobalt radiation machine for the entire country. Next slide. So this is a picture to show Ethiopia, which is in the Horn of Africa, and Addis Ababa is the capital city in the center, and that is traditionally where the single comprehensive cancer center was in the country until recently. Over the last decade, there have been really remarkable achievements in building capacity into tertiary academic centers around the center to decompress the patient load into the other tertiary academic centers. And Hawassa is located 5 hours south of Addis Ababa, and that's where I've had the privilege to work with colleagues over the last decade. I also had international colleagues from Germany who have also worked in the western rural parts of the country as well. Next slide, please. So this is a photograph of Hawassa University. It's 5 hours south of Addis Ababa. There are 300 beds. It serves a catchment area of 24 million people, many of whom are from rural areas. There's a school of nursing, a very comprehensive undergraduate school as well, and a brand new comprehensive cancer building and a linear accelerator, which is being installed this week, which will be the 3rd in the country. Next slide, please. So the milestones. There have been numerous milestones achieved over the last decade to build capacity in breast cancer research, education, and care. This has been because of the work of sustained international collaboration and friendships across disciplines and across groups. So in education and training, there is now a training of radiation oncologists in the country. It's both medical oncology and radiation oncology. It is now, the training program is now up and running and producing graduates within Addis Ababa. There's been training of epidemiologists who have done critical work in understanding the magnitude of the problem. And there are also training of nurses in oncology and in breast cancer research. Chemotherapy access has improved. Just speaking from the perspective of breast cancer, there's access to anthracyclines and taxanes available. An essential database was created. This is the Addis Ababa City Cancer Registry. It's a population-based registry. It is the only registry for the country. That registry provides information to GloboCan, and that it provides information for global health organizations to allocate resources. It is essential. However, as I said before, 80% of the population lives in rural areas, and it is impossible to capture the magnitude of the problem from an epidemiologic point of view with one single population-based registry. So a lot more work needs to be done. Nevertheless, it provided a lot of really excellent data to show that the magnitude of the problem, and that breast cancer is the most common malignancy. We also now understand that breast cancer biology is 2/3 of it is ER positive, estrogen receptor positive, which if caught early with early detection could theoretically be treated with a mastectomy and a tablet called tamoxifen costing $3 a month if detected early. So again, building on the themes that Dr. Anderson spoke about this morning, it is tangible. These ability to improve survival from breast cancer is tangible and within reach, especially with this knowledge now that we have that 2/3 of the breast cancers in Ethiopia are estrogen positive. Within the field of epidemiology, we know that patients present young. This is a reflection of the young the young population structure of the country. Most patients are between the ages of 35 and 45. They present with locally advanced disease, stage 3 or 4 disease. And there have been multiple programs that have been created and funded to decentralize cancer care. And I'd like to just point out that this is a beautiful picture in this article of women who were obtaining a clinical breast examination during a cervical cancer screening program. Next slide, please. So there is a whole lot more work to do. In 2021, the WHO called on the international community to reduce breast cancer deaths by 2.3% per year, which is a tall order. There were 3 pillars that we heard about this morning to achieve. And yet, in Ethiopia, since 2020, there was COVID, civil war, and now food scarcity. Yet, patients still show up. Providers still need to take care of those patients. People still need to be educated and trained, and progress must still be made. Science still needs to move on and discover underpinnings of ER/PR breast cancer biology. We still need to roll up our sleeves and do our work so that we don't leave vulnerable groups behind. Next slide, please. So with the call from the WHO, in response, teams from City of Hope and Ethiopia have worked with me to establish a research portfolio to capture those themes. And this is the overall structure of it. So based on the WHO model, we put together this program, and it has 4 pillars or 4 programs. One is in nursing education. This is to improve and promote health diagnosis and early diagnosis. The other is on pathology capacity to further improve timely access to diagnostics and obtain tissue diagnosis. And the third pillar would be activities in the oncology unit to tighten treatment and comprehensive breast cancer management. A fourth program, which would be a long-term goal, is to advance the study of ER-positive breast cancer biology. And to make this sustainable in a very practical level, I realized that this program had to have very well-articulated bi-directional benefit, meaning that it would benefit everyone involved, not only just the Ethiopian team, but also the City of Hope team. This would be providers, researchers, students, and patients. And also that the benefit had to ripple beyond City of Hope and beyond Ethiopia. In other words, we would be able to develop novel approaches to patient care, broadly speaking, and we would also be able to deepen our understanding of the biology of disease. We had to think big, and we had to plant many seeds, seeds that would endure droughts of funding. Remember, during COVID, there were no walks. With no Komen walks, there's no funding. So there had to be drought-resistant seeds placed. Next slide, please. Where are we? Let me see. Oh, okay. So the practical aspects of project implementation. These involve several things. It involves assembling teams at City of Hope and other collaborators. It involved using logic models to summarize large project ideas so that stakeholders, multidisciplinary teams would be able to utilize a common visual and language. And I'll get into that in a moment. It also involved preparing applications jointly, even though they weren't funded, but just writing many applications. And this helped build team trust and collaboration. It helped really understand the cost of projects on the ground in Ethiopia, and also enabled us to break up projects into smaller pieces so that when large funds weren't awarded, we could still pursue small projects that were meaningful and prioritize them. Prioritization was huge. There are so many things that need to be done. Where do you start? So creating a 5-year budget of the critical components to sustain them over time was absolutely essential, and always undergoes revision. But some key pieces that stay are the team, the core team. Supporting the core team of Ethiopian PIs was absolutely, and the other teams are absolutely essential and need to be sustained over time. And also creating a large variety of projects, big ones and small ones, dream projects and tangible projects that can still have meaning. And also the definition of sustainability. This is a constant theme. What is the mechanism of sustainability for these projects? And I'll talk about those. Then the practical tactical. So at City of Hope, meanwhile, we had to be pitching the portfolio. So this was pitching it to philanthropy, leadership, colleagues, people who wanted to be involved. And so they would be able to then talk about it to others and attract interest. Then the practical is setting up chart string for the project, and then reviewing contracts with legal. So some projects are appropriate to have contract work. Some projects, which are for larger awards, need to have contracts developed between institutions. And so having legal counsel and talking to them and selecting the appropriate contract was a very important process. There's also administration of contracts, which is a whole process in of itself. And then administering addendums to contracts when additional work needs to be done or additional small projects needed to be funded. Then, of course, there's also the logistics of accounting. So monitoring like a hawk the transfer of funds, making sure that it gets into people's accounts, that it's received, that sort of thing. But also navigating purchase orders from, for example, Kenya to make it to Ethiopia. It was also a huge learning curve, but also very practical piece of this implementation. So next slide, please. So here we are. Here's the team. So this team represents a decade of building and sustaining collaborations and friendships. This team is multidisciplinary. It's international. I'd like to highlight the components of it. We have 3 Ethiopian co-Is, one in nursing, Bedalu Daribe, he's the head of the nursing school. We have the head of the pathology department, and we also have the radiation oncologist who's the head of the cancer center. Again, Each of these folks represents one of the major pillars by design, and also are essential to collaborating with each other and with our teams here at City of Hope. With the City of Hope team, we have a multidisciplinary team across many disciplines. So we have breast surgery, myself, right? And we also have Dr. Betty Farrell from Nursing Education and Research. We have surgical pathology. We have surgical oncology, medical oncology, radiation oncology. We have a physicist. We have supportive care medicine, international medicine. We have fellows involved. We have an infrastructure team, like I talked about, from legal to the business manager, contracts administration, and accounts. And then we also have external collaborators. So I want to point out here that I've been working with Michelle Rakoff, who's a patient advocate since 2015, since Komen Projects. And she's been just a remarkable advocate and proponent and contributor to all of the research efforts. We also have international collaborators, my dear friends from Martin Luther University in Germany. And this assures that some of our projects and our work are not duplicating their efforts, because when working and trying to affect change in a setting of extremely limited resources with extremely limited funds, we want to make sure our efforts are complementing each other and not duplicating each other. So Dr. Eva Kandelhart from Martin Luther University is working a lot in the primary care and primary and secondary peripheral centers, and I'm working right now mostly targeted in Hawassa at this point with several things, and we'll get into that. And so it's a way of making sure that our efforts converge and we're not competing. And also partnering with an external stakeholder, the BioVentures for Global Health has been a remarkable institution or group to work with. They are working to build capacity in oncology in sub-Saharan Africa, and they've been absolutely wonderful collaborators. So let me just get into some of the nitty-gritty details of it, and I'm going to just highlight practical aspects of the program implementation, so that just to highlight those things for the audience. So for the nursing education program, this has two parts. One is supporting activities in the nursing school, and the other one is training other nurses in the region. So in Ethiopia, there are 70,000 nurses. The reality is in the globally, 80% of healthcare is provided by nurses. So they are an essential resource. They interface with professions across all tiers of the healthcare system, from the primary to secondary to tertiary healthcare system. And nurses in Ethiopia with master's level degrees are expected to conduct research to improve clinical care. They are considered research scientists. In Hawassa, there is a school of nursing. They have 5 undergraduate programs. There are 274 students that graduate annually, 26 master's students with a master's thesis, and 25 surgical nurses. And I'm putting this in there because we're going to be working with them. And I'll get into why later. But in terms of the practical aspects of developing this program, there are large and small projects. For example, supporting nursing students to do a thesis, a dedicated thesis on a breast cancer problem would cost $1,500. And their research is very robust. It's about improving clinical care. And we're also benefiting somebody to create a skill set that they will then take on for the rest of their career, researching ways to improve clinical care when they practice later on. So again, first, for $1,500, we could support students performing their thesis. Whereas doing larger projects, for example, the second project, which is creating a training course in the region with partnering with BioVentures for Global Health, with Dr. Betty Farrell, is somewhat of a train the trainers type of a program, and obviously has a larger budget, a different type of reach. So the impact here is both local as well as regional, with large and small projects. Next slide, please. Oh, sorry. Could I have the next slide, please? So this is a nice picture of us mentoring the students. These are last year's class of 5 students obtaining a master's degree. They did remarkable work, and here's our team of mentors. We have our German team participating in this, patient advocate, Dr. Betty Farrell, and our patient advocate, Michelle Rakoff. And it's a wonderful experience. Again, bidirectional. We learn so much from these students. They learn from us, and we're getting really meaningful data to then implement further projects or further interventions that can impact care. Next slide, please. So the oncology nurse training program, this is a larger program that education intervention that we'll be deploying or launching, I guess, in November. So this is a collaboration between the City of Hope-Ethiopia and the BioVentures of Global Health. We're going to pilot our training program to 30 nurses in the oncology unit in Hawassa, and then test it, revise it. It's a mixture of lectures and didactics with role-playing videos and small group work. It'll be probably last about 5 days, not 3. We're in revisions. And once we test this, we will test the effectiveness of it. We will do revisions, and the long-term goal is to implement this regionally, recruiting 10 nurses from 3 hospitals across 12 countries in sub-Saharan Africa, drawing on the resources and networks that we have, as well as BioVentures of Global Health, to target 360 nurses regionally. So the practical aspects of project implementation are that we're piloting it in Hawassa, we're thinking about regional impact, and in the approach to sustainability. So it's following a train the trainer model of sustainability. In other words, education is the mechanism of sustainability. And the other important piece of sustainability is that by having this network of people who are participating, we've developed a network of collaborations for future work. In other words, we would be able to establish the context to then track changes over time. Next slide, please. So the pathology capacity program. So we talked a little bit about before how breast cancer can be estrogen receptor positive or negative, and this understanding of biology really impacts patient care and allocation of resources. So in the second pillar, following the WHO model, developing pathology capacity is absolutely essential to impacting care and treatment. So the idea here, again, is to develop high quality specimen handling, processing, and analysis of breast cancer specimen in Hawassa to improve diagnosis and treatment, to learn from that experience and apply it and see if it's applicable to other settings in sub-Saharan Africa, and also to implement an educational program in manual immunohistochemistry staining across the region to then establish networks of resources and collaboration. Next slide, please. So the practical aspect of developing this one is that we had to start from scratch because there is no manual immunohistochemistry staining in Hawassa. So we followed the Paul Farmer approach. Paul Farmer, as you know, is an amazing public health genius, leader, and he talked a lot about assessments of space, staff, and stuff. That's the easy way to remember it: space, staff, and stuff. And so we had to start with an assessment of our staff, that also our stuff, and this involved external audits from people that we knew from Kenya to come and look at the lab and give a sort of objective assessment of what shape it was in and where it needed to go, and also give some recommendations about what kinds of equipment would be realistic in the setup. We also had to start building the infrastructure in the sense of if we were going to purchase reagents for estrogen staining to figure out whether the breast cancer is estrogen positive or not. we would need to establish the purchase order, the contact, get them cleared through customs from Kenya to Ethiopia, how it would be picked up and then delivered to Ethiopia, all of those nuts and bolts. Next slide, please. So again, it starts with the assessment of the space and the stuff. So this is what we were dealing with, the yeses and the nos, and where the specimen were handled, what shape they were coming in, what were the containers. Next slide, please. And we also understood that in order to start anywhere, it was absolutely essential to engage and train the technicians in the lab. So if we had to start there. So this is when I called a friend. So I called up BioVentures for Global Health and I said, listen, I'm having a hard time finding any kind of an accessible or affordable training program for immunohistochemistry techs for sub-Saharan Africa. We would need to pay for them to go to Kenya. It would be an expensive course. They'd have to leave their homes. It'd be totally inconvenient. Is there anything online that we could do? Is there anything that we could put together? And so we recognized this was an unmet need and we were going to fill it. And not only were we going to do it for Hawassa, but then we realized that regionally it was a real unmet need. And therefore, we realized that what we did in Hawassa could ripple regionally and have impact regionally. So we started to think big. And we created a multidisciplinary team. These involved friends from South Africa, Germany, Australia, and Ethiopia. And we created a webinar that went over 3 days, with 6 lectures. Next slide, please. And we talked about immunohistochemistry, staining and theory. We had over 370 registered participants from 11 sub-Saharan Africa, 266 participated. And then we realized that we wanted to sustain the education. So we created a virtual education platform after the webinar, and 60 people signed up with that from 10 different countries and stayed participating. You can see a picture of the platform. Many people in our surveys had said that they were comfortable with social media as well as mobile devices for education. Next slide, please. And we continued to post. Our progress up on the website. So when we started launching manual immunohistochemistry in Hawassa, we posted the progress onto the website. These are our technicians in Hawassa were trained. Again, this is the investment in the staff, in the people, to perform at their highest and to be motivated, involved. And there's a picture of Dr. Lisa Yee and Dan Schmolze and myself reviewing the slide. So we are up and running, performing manual immunohistochemistry in Hawassa. Next slide, please. We then, as a group, started to put together a logic model because we realized we had short-term and long-term goals. And so this project for pathology capacity is now a very long-term project, right? And so it started with a webinar, and then we have a virtual mentorship program. But then we realized we could start having mini webinars. And so we, at 6 months time frame, we sent out surveys again to see what had happened with our participants, but also we wanted to give a mini webinar as to what we were doing in Hawassa. So we developed a logic model. It keeps us all on the same page and it enables us to have a timeline to stay on track for our objectives and meet our milestones. And we can evaluate our outcomes, and it helps us prepare for abstracts and manuscripts, and it can also be used in future applications. And so there are really wonderful resources. This is implementation science. I'm not an implementation scientist, but I use the logic model. So there are resources from the NIH and from great groups from Northwestern, for example, that put this out, and we did it and we used it and we learned by doing, and it's been very useful for us. Next slide, please. So we then started working on optimizing specimen handling of breast cancer specimens. So as a surgeon, that specimen, after we do the mastectomy, needs to be handled as if it were the extension of the patient herself or himself. And that specimen needs to go in formalin within an hour so that we can properly handle it, and so we can understand whether it has estrogen receptor on it or not, because that impacts future treatment. And so surgical nurses are absolutely essential in this. And we implemented a training in Hawassa. We trained 35 nurses on this. They loved it. And then we did a mini webinar featuring this, as well as the implementation of manual immunohistochemistry and the lessons learned. And we had over 100 participants in the mini webinar, and it was 95 participants. And then they viewed the videos from the webinar over 33 times within a month. And we got data from participants about what had happened from 6 months until now with their progress in developing immunohistochemistry staining, and 52.7% of those people who responded, so that's 50, we had submitted a survey to about 300, and 52.7% of participants reported a moderate or significant improvement in the quality of their slides. So the work matters. Next slide. So I'm just going to briefly talk about the oncology unit. So this is the third pillar that we're also working on, and we have projects within that. So there's advocacy. So this identifies opportunities to support patients and interventions to improve outcomes. There's a breast cancer specific database, which we are trying to pull together the variables that can be then used in the future. Okay, and then we also have the multidisciplinary tumor board, which is quarterly, and we are also building capacity for launching of the radiation oncology project, which will be the third in the country. Next slide, please. Okay, so I just want to make sure I'm okay for time. This is a picture of our advocacy project. So, the role of advocacy groups and patient advocates has been really responsible for the progress of breast cancer research, public policy, and shaping our culture awareness about breast cancer. And it has been absolutely essential in getting us in the United States where we are today. For example, the DoD funds breast cancer research because of breast cancer advocates. The laws about mammographic screening are because of the work of breast cancer advocates. So advocacy is really an essential part of affecting change on a local level. And so for the practical aspect of this program development was thinking about sustainability. So, getting a patient advocate, we got a patient advocate from the United States involved. We also are getting our breast fellows involved in this project. And also the project was affordable. It was small. We could generate both large and small projects from this data that will impact patient care in a real tangible way that maybe patient advocate groups from the United States would want to partner with in Hawassa. Next slide, please. The Breast Cancer Ethiopian Tumor Board, we do this. We launched this last February. We have our tumor board quarterly. It provides opportunities for bi-directional education. The breast fellows are involved, and it provides insights to discuss future opportunities. And of course, it's bi-directional. We learn so much from them, and they learn from us. Next slide, please. So outcomes. The outcomes of this, we've jointly prepared multiple manuscripts. We've been awarded extramural funds. Dr. Betty Farrell and myself have been honored to be appointed as adjunct faculty in the School of Nursing. Nursing students are preparing manuscripts. They've graduated with their master's degree. We've built a collaboration with an external stakeholder. We've created networks of collaboration across sub-Saharan Africa in this virtual mentorship program for pathology capacity. We've had joint publications, and we've also received philanthropic funding. Next slide, please. The whole point here is that the big picture is that 1/3 of breast cancer deaths in sub-Saharan Africa can be prevented in the next decade with improvement in diagnosis and treatment. And the big picture is that what we do in Ethiopia can ripple regionally, but also globally. Thank you.
Thank you very much. This has been very enlightening. Because of the time, Dr. Taylor will answer the questions in the chat directly. But I have one question for you. So Ethiopia spends right now $27 per capita per year for each individual. That's 3% of their total GDP. Just to put it in comparison, the United States pays $12,000 per capita, and it's 19% of our GDP. And the priorities, if you look at mortality in Ethiopia, the number 3 mortality is maternal-related, infectious disease, and trauma. So why should we spend money or training in this? Why this needs to be a priority versus doing the same type of investment on the 3 issues that really affects Ethiopians right now?
Yeah, that's a really great question. So the mortality from breast cancer is the same as maternal-related deaths, and yet there are millions of dollars from NGOs that are invested in reducing maternal mortality, but there is very scant funding for breast cancer. So while it is a problem, remember, breast cancer is affecting a certain population. The mortality is very high from breast cancer. And mothers are an essential part of these mothers are essential part of the community. So with the financial toxicity and also the potential loss of life, you're really impacting the community and children. We heard from Ben Anderson the amount, it's a generational problem because of the orphans and a real loss of the centerpiece of the family. Women are collecting fuel for food. They're farming. They're doing multiple tasks as caregivers. So it's a real, it's affecting the heart of the community.
Thank you very much, Dr. Trisal and Dr. Taylor. This concludes our session of Global Oncology. I think that, as both of you exposed, the challenges are far larger than we anticipate, and we only scratching the surface. But your job, Lesley and Vijay, are extremely important and to reduce the inequalities of healthcare, especially when it relates to cancer care. Thank you very much to both of you.
Thank you all. Thank you, Ben.